Yeah. Beautiful. I'll see you in a few minutes. Yep. Patient call. But the reality is, even though we're supported by the state, that doesn't mean we have adequate support by the state. And as you can imagine, I would say 50% in round numbers of the patients we see are Medicaid patients. About 15% are charity care patients. So the revenues that we generate, we do a lot of work. I mean, we're very busy, as I'm going to show you. But the reality is the revenues we generate are not consistent with the amount of clinical work that we do. And that's why we need various sorts of extramural grant support. And a really key source of that support has been the Alliance over the years. And the Alliance have actually given well over $2 million to support the department. And as you all, I hope, know, the Alliance contributed to the Alphonse Sinati Alliance Eye Research Chair of Ophthalmology. And that's an endowment that generates money of the faculty. So I just can't thank you enough. I know it's a big sacrifice on your part to support the department, and I want you to know that we really appreciate it and count on it. It's been quite a busy year. We've had a number of major events occur in the department. Let me just see if I can understand how to project this now. I want to put this
right up at the top.
I'll get it.
That TV looking thing right there.
I just want to put it on a slideshow.
Yeah.
Yeah, please.
No, it's a.
I have to just get it on the. This is presentation, right?
Yes.
Go up to the orange. Yeah.
Is it broadcasting?
No, just this camera. You have to put the hybrid.
Yes, I'm hearing you. Can you just share the screen and then?
Can I continue?
Yeah, please.
So it's been a very eventful year for us. We had 2 faculty members retire, and 1 just died this week after an extended illness. So big changes in the number of faculty. And very fortunately, we've recruited 1 new faculty member who you're going to hear from today. His name is Prashanth Iyer. He's an excellent retina surgeon, an intrepid surgeon, and he's been working like an animal, which is very humble to me. But the related, I'm telling you about these changes in part because I want you to see the effect they've had on the department's volume. But in addition, I have to go to the graveside burial of the faculty member who died this week. So I'm going to be leaving this meeting a little earlier than I'd like to, but I just want you to understand why. Now, in terms of what's been happening, you know, and I apologize for the lack of formatting of the slides. The slides are actually correctly formatted, but for some reason, when we transfer them to this computer, the formatting becomes misaligned. But I can just tell you what I want to tell you. You know, we're the only residency training program based in the state of New Jersey. New Jersey, highest population density in the United States, actually. And about 25% of the ophthalmologists who practice in the state have been connected to this institution at some point in their career, either as medical students at New Jersey Medical School, where they rotate in the ophthalmology department, or actually having completed their residency training here. So the quality of the residency training that we do has a profound impact on the quality of ophthalmic clinical care that's provided to the citizens of New Jersey. And of course, clinical training is what we are all about. That's one of our primary missions. And I want you to know that this is an outstanding residency training program. And I say that having been trained at an outstanding program, and without any question, the quality of the training that the residents have is at least as good and probably better than the training that I had. And the reason is because they're very, very, very busy. In fact, I would say not everyone has the stamina and the resilience. Stamina is a physical thing. Resilience is a psychological thing. To be a resident here, it's a very demanding residency, but they learn a lot, and they become very, very skilled decision makers and surgeons as a result of the training they have here. But in addition to that clinical training, the other thing they have to develop is an intellectual approach to being a physician. And that best way to develop an intellectual approach is to be an intellectual. And to be an intellectual means to write. And this is a list of the resident publications. And you can see every year, let me just deal with it. The number of publications, and what I want to show is in last year, they generated a total of 88 publications. Let me assure you, you could go to Hopkins or you could go to Harvard and you wouldn't see many more, if any more, publications generated by the residents. So they're very productive intellectually. That's this year. But now the formatting's perfect. Good. The faculty, of course, are very, very busy. I can tell you that even when we have the full complement of faculty, which we didn't, you can rank productivity, and it turns out that all the academic ophthalmology programs in the United States, or actually 70 of 114, submit their productivity data for comparative analysis, and we do that. And our faculty, more than 90% of them are above the 50th percentile. More than 75% are above the 75th percentile. Some people would say that's too busy. And I don't really think you can be too busy as a surgeon, because the busier you are, the less surprises you have in the operating room. I don't know if that makes sense. But you want to be, let me just say, you want to be operated on by somebody that's at least at the 75th percentile of productivity if you're talking about surgery. So that's a core part of their mission, being good doctors. But as I've just alluded to, another core part of their mission is being good teachers. And again, you can't be a good teacher unless you are experienced clinically and you're intellectually very active. You need to know where your field is and where it's headed, and where it's headed may be in some directions good and in some directions not good, and you need to know the difference. That's your job as an academic physician and a teacher of young physicians. So the key for that is also being intellectually productive, and the faculty are intellectually productive, and you can see year by year, I'm focusing on just last year, 195 total publications of various sorts. And again, that's, when you consider how clinically busy they are, that's a very high level of productivity. So I want to assure you that what you're contributing in terms of the financial support to the department, you're investing in excellence. You can be very, very confident about that. And I can tell you that people who are really not excellent don't last very long here because they get burned out. In terms of the volume, as I mentioned to you, essentially we've been down 3 faculty members on and off during the past fiscal year. And so it's not surprising, now this is out of format, that our overall volume went down by 6%. Think of it, we only had a total of 12 full-time faculty members, used 3 of them. So that's a 25% reduction in your faculty, and you only have a 6% reduction in your volume. That's pretty impressive. And the surgical volume went down even less, 0.8%. So while these are negative numbers, they're only negative if you don't standardize them per capita. The truth is, people are really, really busy, and our department is like a leading economic indicator. The worse the economy gets, the busier we get, because people drop out of the higher paying insurance plans because they can't afford it, and they end up on things like Medicaid HMOs, which are cheaper. And that's why most of our 50% of our volume involves Medicaid and Medicaid HMOs, actually mostly Medicaid HMOs. Okay, now this is not a good picture. This is how long it takes to get a new appointment. And I can tell you, no private practice would want to have it be even a month that it takes to get a new appointment, let alone 2.5 months, let alone 14 months. So we need to hire more faculty. Of course, we then have to figure out where we're going to put them and where we're going to see those patients, because if you come here most days of the week, it's a little bit like Grand Central Station. And we're working on that problem. But the good news is that we are actively recruiting cornea specialists and looking hard for pediatric ophthalmologists. They're very hard to find. And probably going to recruit another retina specialist. So hopefully I'll have some good news on this front next year. But it's a really important problem that we're trying to attack. And by the way, having the Sonati chair is really important in assisting us in those recruitment efforts, because it creates working capital that I can use to help support those recruitments. The OR utilization, I'm just showing you this for fun. We are the largest users of the outpatient operating room. You can see 36%. I mean, there's no service that's even remotely close to us. And we're using it all the time. And then if you look at the surgical volume per surgeon, those red or whatever color that is, those are ophthalmology surgeons. So we are basically the busiest surgeons in the outpatient operating room, which is, of course, what you'd expect. But what you might not realize is that some of these surgeons, I'm going to use Dr. Guo as an example, is one of the busiest surgeons at University Hospital. So not just the busiest surgeon in the outpatient operating room, busier than the cardiac surgeon, busier than the neurosurgeon, busier than the general trauma surgeon even, okay? So we're very busy. But busy is good. I'm not complaining about being busy. One thing that I think won't surprise you, but I think surprises a lot of people, is where our patients come from. And the easiest way to say that is just to say how many people actually come from Essex County. And this has been true for as many years as I've been tracking it, which is at least 20 years. Only 50% of the people we see come from Essex County. 50% come from everywhere else in New Jersey and outside of New Jersey, even outside the United States. And I'm not talking about illegal immigrants. I'm talking about people from Europe and that kind of stuff. So we really are serving everyone in the state of New Jersey. I want to make that absolutely clear. This is not some kind of charity care operation. It's a place where we take care of all kinds of patients. People who are really rich, people who are really poor, people who don't have a home, people who don't have a family, and they all have complex problems. And we're very happy to do it. But don't think for a second that because we're a state institution that the state provides adequate financial support for the work that we do, because it doesn't. And I'm not trying to criticize the state, I'm just stating a fact. Okay, so that's really what I wanted to tell you about the update, and if you have any questions about it, I'm happy to answer them. Okay, so the next now comes what is the fun part. So I'm going to tell you a little bit about something new that we've been doing over the past couple of years. Now this has to run off of my Victorinox.
Yes.
Great. And then Dr. Iyer is going to speak, and then Dr. Turbin is going to speak. And we're all going to just share basically what we're doing that we think is fun. There's the resort.
The font is open.
Close that.
Yep.
Close that.
Yellow track.
This one?
Yep. Yeah, that's it.
Hit show. Hit show.
Hmm?
Show.
No, give me 1 second. Let me just get it on the screen.
Hit hide.
Okay, so I'm going to tell you about a treatment we've been using. We didn't discover it, we didn't invent it, we've just been using it a lot. It's called methotrexate, and we're using it to treat the severe scarring that occurs in patients with certain types of retinal detachments. Now, methotrexate, you may already be familiar with, it's an anti-cancer drug. And it turns out that it's been used in the eye for a long time, but not for the purpose that I'm about to show you. And this is work that I did with residents. So Patrick Hughes, who's now a Retina fellow in Manhattan, and Nathan Aji, who's a Retina fellow over in Oregon. 2 excellent training programs. And these are my disclosures. The only one that's relevant is that when this drug was being tested in clinical trials to see if it was effective, the company that was running or sponsoring the trial was named Aldara Therapeutics, and we were participants in the trial, and I was one of the investigators in the trial, but I have no financial interest in this product. I want to show you a video of a surgical procedure. I didn't make this video, but the guy who thought of using methotrexate for the purpose that I'm about to show you, he made this video. His name is Dean Elliott. He's a professor at Harvard Medical School. And we were actually residents together. So let me take you through. This is the video of an elderly man who had fallen and injured his eye, and he has a very severe injury with a retinal detachment, blood in his eye. And the first part of the video is actually not important, but I don't want to disrupt the tempo of what you're seeing. So Dr. Elliott's drained the blood from around the eye. Now he's taking the damaged lens. This is what I want you to see. That what you're looking at right now is the retina, and it's not supposed to look that way. It's all folded up. It's actually supposed to be flat and against the retina. That is because of a condition called proliferative vitreoretinopathy. It's a scarring disease. That's the disease we're trying to treat with this medicine called methotrexate. And what you're seeing now is Dr. Elliott has taken out the scar tissue. He's reattached the retina, and that white spots are laser treatment that's intended to seal the retina against the eye wall. And that looks really beautiful. And in fact, this patient actually happened to do remarkably well. But generally, that's not what happens without the methotrexate. Generally, what happens is you leave the operating room with the retina looking just in that beautiful way that Dr. Elliott left it. But then you get this healing response, which creates scar tissue. And what it can often end up looking like, and this is not Dr. Elliott's patient I'm going to show you next, this is a patient of mine before methotrexate. And what you can see here is this doesn't look right. You don't need to be a doctor to understand that. All this is scar tissue around the margins of the incision, and it's pulling the retina off the eye wall. In fact, if you look carefully, the scar tissue is going all the way out to the front of the eye. It's a mess. It's not what we want. And this medicine, the methotrexate, helps prevent that scarring response, and it does it really well. That's the scar tissue, and that's the scar tissue going out to the far periphery. So, methotrexate interferes with DNA synthesis. That's the chemical structure. It's actually been used in medicine, as I kind of indicated, for a long time, in cancer treatment and in rheumatologic diseases. We even used it in ophthalmology to treat certain types of ocular inflammatory diseases like sympathetic ophthalmia. And we also use it to treat intraocular cancer. In fact, the guy who developed the dose of methotrexate that we use, his name is Dave Wilson. And he also, he was a fellow when I was a resident. We worked together at Hopkins. And so Dr. Wilson worked out the dose to treat the cancer in the eye, and that dose is what we're actually using, more or less, to prevent the scarring in the eye. And it doesn't last very long, unfortunately, once you inject it into the eye cavity, and that's why the patients that get the treatment need to have a series of injections after the surgery. And a number of investigators have demonstrated that this drug can prevent the scarring or really reduce the scarring. But the pioneers that really showed this were Dean Elliott, who I've mentioned, and his resident at the time, Tommy Strajewski. So they really deserve the credit for pioneering this treatment, in my opinion. So in the trial in which we put participants, in order to be eligible to enroll in the trial, you had to either have a detachment or a recurrent detachment that had the scarring disease, which is called PVR, or you had to have a detachment that had a very high probability of developing PVR. So that would be a detachment associated with trauma. And of course, the patients had to agree that they'd be willing to undergo a bunch of injections after surgery. And those are the criteria that we use even today, now that the trial is over. And the procedure, these are technical details that you mostly won't be interested in, but I think the key detail is that you've got to get these injections after your surgery as well as during the surgery. And, that's not nothing. And then we have the patients lie flat for about 20 minutes so that the drug will diffuse back to where the retina is. And the patients that we're talking about that I'm going to show you have really terrible injuries. So they have a lot of additional surgical procedures done, not just retinal reattachment. And these are the patients. I don't want you to focus on the details. I'm just going to tell you some general comments about them. They tend to be about age 56. You can see that about more than half of them were eyes that had undergone trauma. And they had a lot of, every one of them had scarring, but more than half of them had the most severe possible scarring. And, when things get really bad, when you can't take the scar tissue off the retina, you have to make an incision in the retina, like you saw in that video. And more than, almost half of these people had a complete incision of the retina, which is an indication of how severe the scarring was at the time we operated on them. And they've been followed for a long time, and ideally, you end up getting 13 injections. We don't always achieve that ideal because of complications that can develop, but most of the patients got close to 13. 80% got 10 or more injections. And this is the remarkable finding that with one operation, 90% of the patients had a successful operation, 90%. Now, historically, when I was as experienced as I am today, so I'm not talking about an inexperienced surgeon, historically, that number is about 70%. So that's a very substantial increase in the anatomic success rate. And in fact, for the one failure, one of the failures isn't really a failure. He's a demented patient who we lost to follow-up. The other one who was a failure was a 9-year-old boy who underwent reoperation, and he actually has been successfully reoperated and recovered ambulatory vision. The main problem with this treatment is people can get what's called a corneal epithelial defect. Some of you may have had that if you wear contact lenses. It's a defect in the skin covering of the cornea. Generally, that's treatable, and it does require suspension of the injections, which is why not everybody got 13 injections. When you have very severe scarring, you can get a very low eye pressure. Some of you may have seen people that have this problem because the eye, when the pressure is low, shrinks and it looks sort of unsightly. So it's an outcome that we don't really want to see happen. And in fact, the treatment seems to reduce the likelihood of low eye pressure. And of course, we combine this treatment with injecting an oil bubble in the eye to act as an internal bandage. And we don't always get to remove the oil bubble for technical reasons. So not all the patients had the oil bubble removed. Anyway, the visual results in these eyes are pretty limited because of the severity of their injury. But just say that going from hand motions to finger counting, that can be very helpful depending on what the status of the other eye is. If the other eye sees 20/20, it doesn't really mean a lot. If it's your only eye, and in some cases it is, that's the difference between being able to walk in a room unaided and not being able to do that. And the first versus the best vision is really not too much different. Overall, there was some measurable improvement in vision that I thought was clinically relevant in about 3/4 of the patients that underwent these procedures. So now I'm going to show you some pictures because I think this will illustrate better what I was trying to tell you about. So this first patient is a woman who had an infection in her eye, but it actually came from an infection somewhere else in her body. And she got treated for the infection, but it was so severe that her retina became totally detached. And actually, I was trying to talk her out of surgery, but she insisted on having it, so I did it. And she had the most severe possible complications. That's what all that means. But her vision went from just being able to see the light before this procedure to now having vision where she could count fingers. That's what 1/200 means. And her pressure is low. And she got a lot of injections, and she did get the corneal epithelial defect. But what I want to show you, if you look on the left, that's an ultrasound picture of her retina. It's not supposed to look that way. That's the preoperative ultrasound. It's totally detached. And this is what she looks like 7 weeks after surgery. Now, I showed you what severe scarring looks like, so I'm hoping you're going to be able to intuitively make this comparison. You can see she has some scarring at the edge of the retinal incision, but you can see how much less it is. See, the retina's not detached. And if you walk your way around the edges of the incision, it's way, way less scarring. And this is what we want. This is all because of the methotrexate, because of Dr. Elliott and Dr. Strajewski's observations and their intrepid creation of this company that allowed us to do the clinical trial. Here's another example, a woman who had just a chronic detachment with a lot of scarring. Again, just light perception vision, very severe scarring disease. She underwent the usual commando operation, but her vision actually got quite a bit better, 2400. So she could actually see the large E at the end of the room. Again, her other eye sees perfectly well, so this is still a spare tire eye for her. But if God forbid something happens to her good eye, she has the ability to function really at a very high level with vision in her left eye. She didn't get all the injections, and again, it's because she developed this corneal complication that led us to suspend them. And again, here is her preoperative ultrasound. That white line is the retina totally detached, and the irregularity, the folds in it, are because of the scar tissue on the retina. But here she is 3 months after surgery, and her retina is totally flat. Now, over here at one end, you can see there's a fair amount of scar tissue, but it's not tenting the retina up. But if you look elsewhere, totally flat, just like the other patient. And if you want to really look carefully, there's a little bit of scar tissue in the center of her retina, which we call an epiretinal membrane. So that's it. I just want to show you that this methotrexate treatment really can reduce intraocular scarring in patients that have very severe retinal detachments. It doesn't make the vision get better. That's going to be determined by the health of the retina and the severity of the detachment, but it makes the anatomy get better. If you don't have good anatomy, there's no way you're going to have good vision. It reduces the likelihood that the eye pressure is going to be really low, and it can be associated with important complications, and that's what we monitor the patients for every time we're doing the injections. This is just our own, this is not part of the clinical trial. This is our own uncontrolled data. Since we put these data together, we've done another 20 more patients, basically the same results. And it's really now become part of the standard of care for me when I'm taking care of patients that have trauma-associated retinal detachments or detachments associated with severe scarring. Thank you for your attention. And we did publish this, by the way. I didn't give the reference because I don't think you're all going to read it, but if you want to, you can actually find the published paper.
I have a question.
Yes.
I'm curious about the oil bubble. Is there any negative implications for leaving it? Is there a reason why you can't remove it?
So the question is there any negative implications for leaving it? Is there any reason you can't remove it? This is a great question because it illustrates a general problem in medicine, which is there are no straight answers to straight questions. So the reason we put it in is to act as an internal bandage that could be there forever. And it's clear and you can see through it. And it can help keep the pressure elevated to a normal range. But it can also damage the cornea and make it cloudy, which would interfere with your vision. It can make the pressure go too high, in which case you have to remove it. And sometimes, if everything looks good and you remove it, the pressure then goes down. So the people that we've left it in really fall into two categories. The first category is people where their pressure was borderline okay, and I thought if we removed it, the pressure was going to go down and the eye was going to shrink. The second category is the patients who were so happy about the retina being attached and paranoid that if we removed the bubble, it would redetach or the pressure would go low, that they didn't want to have the oil removed. And I was okay with that as long as their cornea was clear and their pressure was okay. Does that answer your question?
Yes, very well, thank you.
Okay. Well, now I'm going to introduce Dr. Iyer. He is going to show you ophthalmology is a very visual specialty, as you can probably see. And he's going to show you a lot of retinal images of different conditions. He's very interested in retinal imaging. And I'm looking forward to his talk. I've already apologized to him because I know I might have to leave before his talk is over, since I'm going to leave here at around 10 of 10 and we're going to be at graveside. Find the graveside, be a graveside in time for the burial. So, Prashanth. Oh, if I may, let me get rid of this.
It's got to be ejected.
Ejected. So now how do I get to that?
The manila folder.
The manila folder.
I'll get it. Want me to do it?
No, I can do it. This.
Right click. Eject. You might have to close the PowerPoint.
Oh, wait. You're right, I will have to. You're absolutely right. I'm going to have to get rid of this. Done saving. And now, I think eject.
You might have to close it out completely. We did have another one in the background.
Yeah, you're right. Eject.
I just want to get on camera. This way my wife knows I wasn't lying. I really did come here. I didn't see it. I get busy.
Sure.
So I don't have to go on camera. I don't want to miss some good images.
All right. Hi, everyone. My name is Prashanth Iyer. I'm one of the new faculty here at Rutgers and JMS. I'm assistant professor in the Department of Ophthalmology and also the associate director of the Retina service. So it's very nice to meet everyone. Looking forward to meeting you guys after the presentations. Let me start out by just telling you a little bit about myself. I was born in Secaucus, New Jersey. I grew up in Bayonne, New Jersey, and I did my undergraduate studies at Rutgers. I went to Dartmouth to get my master's in public health, and afterwards did my medical training at Jefferson in Philadelphia. Did my residency in Philadelphia as well, and I was very lucky, very privileged to do my medical training at the world's best eye hospital known as Bascom Palmer in Miami, and I was able to do my surgical training at the prestigious Tufts Harvard combined program, Tufts OCB in Boston, and now I'm here. So for me, this is like full circle, starting at Rutgers, coming back, and I'm very glad to be here. My story starts with my sister, actually. She was born with a condition known as anophthalmia. She was born without the eyeballs. And so she was a huge inspiration for me. She inspired me to be an ophthalmologist, and she's had an impact in my life throughout. And she wanted me to, I've been wanting to help people like her my whole life. And so visual impairment is something I've seen my whole life. Not only is my sister blind, but her impact is very strong on my whole family. We know firsthand the struggles that individuals with visual impairment go through. And so now I have a 3-year-old who is also interacting with my sister and is able to learn from her and is able to be impacted by her. So she's a huge influence in my life. It's a beautiful day to save lives, and I love my job. I get to save eyes every day. I get to help people improve their vision on a daily basis. And as a retina specialist specifically, I get to do a lot that I really enjoy. You know, they say eyes are the window to the soul, but the retina is really the window to the body. You know, whatever is happening in your body, you can see in the retina. The way we look at the retina, we put dilating drops in the clinic, and then we're able to see the retina, which is in the back of the eye. This is a cross-section of the retina. This is the front of the eye, the iris, the pupil, and then there's the retina. And so really, truly speaking, this is a normal retina that we're seeing, but the retina really carries clues of things happening in the body. So sometimes we are the first people to see conditions happening that might not be seen anywhere else. You can't see the brain, you can't see the kidneys, you can't see the heart, but you can see the retina, and it can give you a lot of clues. For example, this is an individual I saw in my clinic a few months ago. It's a 75-year-old who came in with some blurry vision, and we checked his blood pressure after seeing this picture. Basically, what you're seeing is the optic nerve and all this blood around the retina. When we checked his blood pressure, it was 200 over 100. It was so high. So we sent him to the emergency room, and we were able to improve his blood pressure, which was causing all these issues. So this is called a fundus photo, and is able to really help us in our daily diagnosis. But this patient ended up doing well. It was able to be plugged in with their primary care and get their blood pressure under control. This is a young guy. He's a 30-year-old guy who had radiation to his thyroid and started having all these issues with his vision. Turns out he has radiation-related retinopathy. The radiation that we did for his thyroid started affecting his retina. You can see all the blood here that's affecting his retina. And so with a little bit of injection and laser, this patient is doing well. His vision is preserved, but we need to watch him closely. This is a very interesting case. This is a 40-year-old individual who's deaf who came to my clinic with all these changes. You know, they have these color changes called pigment changes. The optic nerve looks a little bit pale. The vessels are a little bit thin, and both eyes have these changes. The center of the vision, known as the macula, is very thin and very brittle. And so this patient has very characteristic findings of a condition as retinitis pigmentosa. But along with their hearing condition, they have a systemic syndrome known as Usher syndrome. We're able to get genetic testing to prove that this is Usher syndrome. And this individual is following me daily, weekly, monthly, and now every few months we're able to see them and monitor their condition. Before I get to the next condition, I wanted to show you a little machine we use known as the optical coherence tomography, or called OCT. This is a machine I depend on a daily basis, Dr. Zarbin as well. So the OCT is a machine that basically, let me show you another picture. How it works is it uses a light source in the machine. It's a laser. The laser is a very safe laser. It's called a near infrared luminescent diode. And this laser goes into a splitting beam. Half that laser goes into a reference and half goes into the eye. And what happens is that light is reflected off the different surfaces of the retina and it bounces back. So the light that bounces back is detected, and the intensity or the reflectivity of that light is compared to the reference and is able to give us basically a picture. It's a lot of complicated description, but basically we use an algorithm to use the different reflectivity to create a picture. And what that picture shows us is over here. It's a cross section. It shows us the different layers of the retina. If you think of the retina as like a cake, the surface frosting is called the enfos, or the structure. So we are able to see a bird's eye view of the retina, like the frosting of the cake. But if you want to see the layers inside each layer, then we're able to get the B scan, and that B scan is able to show us the cross section and the different layers of the retina. So that's what the OCT helps us to look at, the different layers of the retina. This is the different layers of the retina that we're seeing on a daily basis. So getting back to my next example, this is a 75-year-old gentleman. On a quick glance, this looks like a normal retina, but he has a little bit of changes. His vision's a little bit down. He was complaining of some vision changes. So we use this OCT machine to get a better idea of what's going on. And what we see is that there's this very abnormal whitening, which is very subtle, but this whitening is not supposed to be there. You have little patches of whitening on the other side. So this whitening told us that the micro arteries in his retina were occluded. So basically he had a stroke in the eye. Wow. He had a stroke in the eye. Not only that, he's at very high risk for having a stroke in the brain. So when we saw this, what we did is we sent him to the emergency room. We got ultrasound of the heart, ultrasound of the neck, brain imaging. We were able to help him. He was able to start on aspirin and all the right treatments. So we basically caught a stroke in the eye that could have affected his brain. So the OCT machine is very, very useful. We use this on a daily basis. It's very helpful. This is one of my favorite cases I saw in fellowship. This is a lady. She was an 80-year-old lady who came in with some blurry vision. I took a look at her retina, and I was able to see there's this lesion that's not supposed to be there on the top. We did OCT imaging, and we saw that that lesion was raised. This lesion could be anything. It could be blood. It could be infection. It could be cancer. It could be anything. So we really didn't know what to do. We did some lab imaging. We got a chest X-ray, and we sent her to the primary care doctor. Before we sent her to her primary care, she had all these subcutaneous lesions in her head and her arm. And so we let the primary care know. The primary care doctor sent her for a biopsy. She also had that lung lesion on the chest X-ray. So that was also sent for a biopsy turns out she had metastatic lung cancer. And the reason she had it, that we were able to get this, was because we saw this in the retina. So that metastatic lesion from the lungs went to the retina, went to the skin, went to the lungs. And so we were able to get her the treatment she needed. I love this t-shirt. It says, being a retina surgeon is like riding a bike, except the bike's on fire, you're on fire, everything's on fire. And as retina surgeons, we really deal with one of the hardest surgeries that we see. This is an example of a retinal detachment. Dr. Zarbin showed you some very complex retinal detachments. It's a different type of retinal detachment. It's called a giant retinal detachment, where the tear is so big. And I wanted to show you a video of how we repair these surgeries, just to give you an idea of what we do on a daily basis. So once we're in the eye, you can see this is the retinal detachment here. It's flopping around. The goal of surgery is to relieve all the traction that's on the retina so that it doesn't detach against, relieving all the forces that are pulling the retina out. So you can see here I'm cutting all the gel that's in the eye. It's called the vitreous gel. That gel is pulling the retina, and we're able to cut all that, relieve all that traction from the retina. And once we do that, we're able to inject a heavy liquid known as perfluoron that basically steamrolls the retina flat. You can see that this perfluoron heavy liquid is going to steamroll the retina flat. And once we get the retina flat, we're able to put some laser to weld the retina shut down so that this doesn't happen again and the retina stays attached. And then once we laser, we remove any excess fluid, we remove the perfluoron, and we exchange it with oil, like Dr. Zarbin has shown in his last case. And so here we're removing that perfluoron and we put oil in exchange. And this patient did really well. They ended up being, I think, very good vision, driving vision. So this is just an example of showing the oil being put in. All right, so I wanted to just show you a day in the life of a retina surgeon and a retina specialist. I want to tell you a little bit about the research I'm doing, which is on OCT, which we talked about a little bit earlier. You know, we have all different types of retina conditions, macular degeneration, we have retinal detachments, we see all these conditions, but the population that I see the most here at Rutgers are diabetics. Diabetics are, 80% of my day I see diabetics. And when you have diabetes, what happens is the sugars cause those blood vessels to become weak. There's a layer in the blood vessels known as endothelium, and it weakens that blood vessels, causes the retina to leak, to bleed, and when there's a lack of blood perfusion because of diabetes, the retina starts to produce abnormal blood vessels. I wanted to show you some areas of abnormal blood vessels that are created in the retina. When those abnormal blood vessels form, that's bad. It can bleed, it can cause problems, it can scar, and it can lead to retinal detachments. So we want to catch these scarrings, these blood vessels, before they form. And it's hard to see sometimes. It's very difficult. The retina is bleeding anyway. You don't know, is this a blood vessel or bleeding? So it's really important to catch these blood vessels in diabetics. That's the most important thing. How we traditionally look at these blood vessels is we inject dye into the vein. And while we're injecting this vegetable-based dye, we take pictures of the retina, and we're able to catch these abnormal blood vessels. You can see that dye has gone in, and we capture pictures of these abnormal blood vessels over here. These blood vessels are called neovascularization. So trying to catch the neovascularization. But the problem with the dye test is it's invasive. Patients have bad veins. They bleed. They don't like it. Nobody likes to get stuck. They cause stomach aches and stomach upset in like 10% of patients. Everyone's going to have orange urine, orange tears. Their fluids are going to be orange, and very rarely can cause anaphylactic shock, which is a rare incidence, but it still happens. And so that's really not ideal for patients to be getting these tests, but we do it anyway. I was mentioning this OCT scan. You can get an OCT scan through the retina, and you can see the layers of the retina. But the OCT also has a newer technology. It's called the OCT angiography. It acts like the fluorescein angiography, but it's non-invasive. What really happens is the OCT machine gets all these scans. They're called B scans. They get over 200 B scans. And what it does is between each scan, the change in the reflectivity is noted. And that change happens when the blood vessels, red blood cells move. And so those scans are able to detect the subtle movements of the vessels and the vascularity of the retina. And so it gives us information on the movement of blood vessels and thus gives us vascular flow information. And the algorithm that puts in through the machine is able to create a 3D picture for us. So this is a picture of the fluorescein. This is the dye that we do. And you can see all these blood vessels that are stained from the fluorescein. And this is the OCTA. We don't have to do anything invasive, and we're able to capture those blood vessels exactly. So this is a great technology for patients because it's non-invasive, it's cost-effective, it's no adverse effects, it's good imaging. We're able to capture a lot of the imaging. In fact, a study had shown that 98% of the lesions, the blood vessels that are found in diabetics, were caught in an OCTA when compared to the fluorescein. So this machine captures 98% of the neovascularization. It's really good, I think, for diabetics, and it's a non-invasive way of doing so. This is another example of the fluorescein. The fluorescein is usually done on a wide field picture, but the OCTA is able to capture nearly every single neovascularization. So we're able to really take care of our diabetic patients in a non-invasive way. So my research is focusing on using OCTA, capturing those vessels in an effective way. This technology, I guess, started around 2016 and is still continued to be used. It's not very well used in the country, but I think this is serving its purpose. The research I'm specifically doing is I'm looking at a condition in diabetics known as ischemia, which means there's a lack of blood flow. That can cause irreversible vision loss. And we're looking at markers in the OCTA. One of the markers is known as vessel density. It's how much vessels are impacted in the retina, as well as the zone of avascularity, which is basically the area that everyone has where there's no blood vessels. Those get bigger in diabetics. So these markers are very helpful in the OCTA machine in catching patients with diabetic ischemia. And so when we can catch and predict these markers, we can really help patients from not losing vision. That's the next step. There's a new OCTA machine that has a bigger laser. It's called swept source OCTA. That's the newest technology. It's really not in use in the country, only a few areas. That's the next step. Once that comes, it'll be a game changer. This is that zone of avascularity I was talking about. You can see that in diabetics, it gets bigger from this area to here. That can really cause vision to be gone. The future also, they're looking at the OCT technology, looking at the whole retina. We were only able to scan one area, but this machine is able to scan the entire retina. It's going to be a while before this is in use, but it's another exciting future in OCT technology. So OCT technology is really, I think, guiding our way of treating patients. OCTA angiography can really help our diabetic patients. It also helps our patients with macular degeneration. And so this is what I'm trying to explore and I'm trying to do with my research. My residents love the technology. I love teaching them. We have a fluorescein conference every month, and I've kind of replaced some of my cases with the angiography from the OCT. The residents really like it. It's cutting edge technology, and I'd love to answer some questions. Thank you for having me.
I seem to be the token answer question.
No, that's great.
Is anybody post-processing the imagery across like using AI to kind of take maybe the next step?
I'm trying, yeah. We have some med students who are interested in trying to use AI to detect without having like someone manually detect, and trying to create like algorithms to catch diabetics. So I think that's the new future. It's definitely something I'm working on. Yeah.
Yeah, I'm seeing it everywhere.
AI is like can't get away from it, but I think you have to work with it in the best way possible. But definitely something I'm working on for sure.
Cool.
Yeah. All right. Thank you so much for having me.
Thank you.
so much.
Do we want to take a 5-minute break? People need the restroom.
Yeah, we can do that.
Okay. Take a 5-minute break and we'll pull up this. Yeah.
I'll put it in the chat.
Okay. I don't need to. I just if everyone
No,
we're
no,
going to
no, legit
Okay.
point.
All right, we can go then.
No, not that one. No, we did handheld ones, which they take into the original. You have a new presentation?
No, nothing new. We forwarded Turbin.
I'm on the website. I'm new, so there's not a picture or anything like that. We're still working on it.
What is it? Okay, which is forwarded.
It's in the chat. It's official.
Okay.
It's official. We're taking a 5-minute break. Which is, so we'll go back at exactly 10 o'clock.
YouTube or on the streaming system. It'll be out on YouTube.
Good morning, everybody.
Good morning. Good morning.
So I'm Roger Turbin, and I've known many of you for many years, and there are some new familiar faces to me from the wine pairing, which was a great event. So thank you also for hosting that. So hopefully I'll make it through today with my voice. I'm just starting to speak. People like it when I don't talk. The last couple of days my voice was out. So there are a couple photos that I would ask, just no photographs. So there's 2 patients. I'll let you know who they are, and we're going to try and not broadcast them just for some privacy. And I thought I'd talk sort of in 3 arenas. One, a little bit of humanistic approach to what we're doing, and to bring you up to date on some of my work with a recent pilot program on a humanitarian mission that I've been going on for almost a decade now. So it's essentially supported by the department, so essentially supported by Lions, but a lot of individual efforts from the people who you'll appreciate soon. Then I'm going to talk a little bit about thyroid disease in general, and then move forward to some stuff that's fresh off the press. Literally, there's some magazine articles and numerous publications which we'll describe about a really encouraging medication. We'll discuss in some of the work with. We didn't develop the medication, but we are one of the major centers that is doing the phase 2 and phase 3 trials and moving forward. And we'll discuss that. So if you recall last year, I believe, I spoke to some work that we're doing out in Grenada, and one of the Lions came and actually went and visited the hospital where we're doing the work. That was the hospital. So that work is also supported by the SGU Medical School, where they're actually funding my team's travel, room and board when we're out there, but everything else is sort of on us. And I talked to you last year about a pilot program, the first time we instituted the development, and we'll talk a little bit more to this, of prosthetic shells, bringing patients who have blind, deformed eyes out in Grenada, a very strong unmet need out there, and bringing them shells absolutely changes their life. And I think the videos I wanted to show you will kind of give you an indication of that. So we just got back a couple months ago, and I'm going to try and go out there now twice a year if possible. And Grenada is a spice island. This is one of the markets, and this is my current team. That's Cynthia Hinton, who's one of our surgical techs, and myself and Tara LeBoy. And we try and allow other people to make it out there. And hopefully this year, I'm going to reinstitute bringing out one of our residents. We call it a tropical ophthalmology rotation. I was able to do that, and then COVID hit. I brought a resident out for 2 or 3 years, increased our productivity. Surgery made it a little bit easier on me with the work. Then that died down, and hopefully there'll be some funding to bring them out again. This year, over 5 days, we individually did 17 surgeries, saw close to about 100, and a little bit more than that, 100 patient visits. That's myself and the technical service. Of those 17 patients, they were done on 2 days. A majority of them, 8 or 9 or 10 of them, were general anesthesia. And on our 2 surgical days, the first day we were leaving the hospital at 12:30 midnight, and the next day we left at 1:30 in the morning, to give you an idea of the workload. And if we could not publish this one, this is one of the images I prefer not to publish. This is a little guy out there who I've operated on it a number of times, and he's just done wonderfully. Ongoing care, and this is the best part. I'm getting to see your successes, and this is the team. This is the area in the SGU clinic. We look outside, we look to the left, there's a graveyard, above the ground graveyard. And last year I showed some pictures of chickens and goats and dogs coming up to the clinic. Someone tried to give me a goat one year for another person likes to give spices from the Spice Island, and we gladly take the spices a little bit, cinnamon here and there, and some cloves and spice. And then we look to the other side, and you look past the graveyard and the clinics and the beautiful water and a resort. And it just kind of shows the superimposition of the graveyard on the resort in this small island. And so this is where we do our work at the St. George's General Hospital, and literally it's open air, and there's flies flying in and out, and it's a interesting place. One year the roof collapsed on us while we were operating. And attention to the left. So I want to give kudos to Heather Dans, as well as other oculists, but Heather Dans in particular, and her father, who have been devoting their efforts to creating these shells. And what we're seeing here is a number of different things. We developed a system out on the island that I'm working with an ophthalmologist out there who's trained. She's a Grenadian, went out to Cuba and was brought back, and now I'm bringing her up to speed on a number of different things. And she interacts with me during the years, and she's sending me photos that I can get a rough estimate of what the shape of a person's eye looks like, the coloring of the other eye. And then Heather develops these semi-custom shells, I would say, or a few of these are semi-custom. Maybe that one is semi-custom. Some of these others are custom. I'll bring them out there. We have a number of different sizes and shapes and fit them to the patient. We did that for the first time last year, and it was a wonderful experience. And I'll show you some of the results. She also helped me learn how to use a system. It's a polymer, and she hand makes each of these, and it goes into the patient's eye. You inject the polymer, and then I get a mold, and then I can bring the mold back to the States, and then she makes a custom shell. So this is a nice custom here, and some of these are custom, some are semi-custom. They're very close, but the fitting is only an estimate. The technology is the same. The fitting is only an estimate until I bring her a mold that she creates. So last year was the first year we had semi-customs, and I took for the first time the custom molds. And this year we brought them back, and we'll go through some of those clinical images. And we're always looking to expand what we can do. Right now, one of the barriers out there is last year, basically by word of mouth, we communicated, and people were sending in their friends. And this year, I let them know ahead of time what we're doing, and didn't get as many takers for the shells. But we tried to communicate with a public health system, which is nearly non-existent there. And I was calling out to the other ophthalmologists. I think now that people are getting an idea of what we can do, there'll be more takers. But for instance, one of the patients out there who they're very limited resources, but someone who was affluent flew to the United Kingdom and had two of these made, not mine, two of them made out there. And in addition to their travel costs, blah, 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 it cost them £5,000. We're providing this for free. Okay. This year, through BioTissue, and I have to give thanks to BioTissue, they donated this material to me, which I brought out, which is amniotic membrane for the surface of the eyes that allows you to reconstruct ocular surface, which can lead to a number of treatment of different diseases. I used it on some cancers this year, some pterygium, some things like that, but also expanding, and these are frozen, expanding the surface or the fornix that can accept the shells. So it was a new pilot that I brought out there, and we're developing a relationship with the company, and hopefully that will continue. And I was able to use, I don't know, in the States, one package goes to one patient, and this is an off-label use. But out there, we can sterilely cut them and make a package last for 2 or 3 different patients. So we conserved what this material. This is expensive stuff, human tissue. So we conserved it, and I left the rest out with a surgeon out there who's using it. She just communicated with me. She just did a case with it. Then I think potentially the next one might. I don't want broadcast. Yeah, if we could not broadcast this one, and then let me see if I can get this started while we're. So this is a young lady out there, and what she has now is a semi-custom shell after trauma, and she wore this for the year. It really looks quite beautiful. She's a very lovely young lady, completely changed her life. I brought this one out. This is one of the customs, and this is her actually getting it. You'll see me placing it in the clinic, and this is her reaction. That just to give you that emotional, this changes people's lives, and they have no access to anything like this. So if we've done, I don't know, on the scale of 10 or 15 of these, if they were going, this is me, actually putting it in her eye. If we're, 10 or 15 of those, if they were traveling in 5,000 pounds, it's a significant impact on patients' lives. And that's my team and the young lady who works in the clinic. All right. Let's see if I can get through that. All right. So I'm going to now change directions to some of the work that we're doing. And this young lady, Shayna, is actually going to be attending Rutgers Medical School here next year. That's my daughter. And this is a picture of the pathophysiology of basically Graves' disease, thyroid-related eye disease, or sometimes known as TED. Big hot topic in my field. Catherine, do you think you can get me a water or something? Yeah, thanks. This is to oculoplastics and neuro-ophthalmologists is now where Retina was with the anti-IGF and other biologics 15 to 20 years ago. In order to develop this image, actually, my daughter met with Vahe Beeden, who was a developer of a new drug that we're going to speak about with Iridian, and was going through numerous iterations of making this accurate. And what this depicts is thyroid, the pathophysiology of thyroid eye disease. So you remember Barbara Bush, eyeball sticking out. Thyroid eye disease is an autoimmune related condition that until recently, I would say we didn't do a real good job with. It's deforming, affects people's lives, and causes chronic disease that can lead to blindness, cosmetic deformities, eyeballs sticking out, double vision, pain, and inflammation. And we don't have the pathophysiology completely worked out, but we've learned a lot. And most of what I'm talking about has happened in the few years before and since COVID. And we'll get a little bit into that. But there are a lot of different theories, but this is one of the main pathophysiologic mechanisms that a cell, pluripotent cell in the orbit, and you can do a lot of different things, has a number of different receptors on it, including the TSH, it's a thyroid hormone receptor, and interacts. And this is a point of debate, how it interacts with an IGF-1. It's a growth factor. But its interactions with hormones that are basically chemicals that are circulating in the body leads to the deposition of excess proteins in and around the tissue, the development of orbital fat, the development of scar tissue, and the release of inflammatory mediators. And you'll see shortly, it causes big, hot, horrible looking eyes that really have a lot of impact on people's lives, and it's reasonably common. And then downstream, it causes the eyes to be red. This is a bony orbit my daughter drew. It can cause the muscles to enlarge and compress the optic nerve and cause visual loss. The eyeball comes out, the eyelids retract. When the muscles get enlarged, the eyes become misaligned. You can develop double vision. I'll have some clinical pictures that demonstrate it. And so we get this as a phenotype. And a new class of medications developed for cancer, basically, is an IGF-1 receptor blocker, an antibody. And that you may have heard of Tepezza or teprotumumab. And I'll go through my disclosures shortly, but it was predominantly a game changer in our field. So up until recently, when I said we were not very good with thyroid eye disease, there are numerous ways to attack thyroid eye disease. And back in my training, they range from lots of steroids and the attendant problems of steroids, if any of you have been on steroids, potential external beam radiation therapy, treatment of the thyroid gland itself, a host of different immunomodulators that range from monoclonal antibodies against B cells, rituximab, methotrexate, Dr. Zarbin was talking about, a number of different ways to do this. And the treatment of the disease was so varied. If you went to Europe, they did it one way. If you went to the United States, we did it another way. If you trained with a certain person in California, his or her disciples all did things certain ways. I trained in Pittsburgh in what was called the thyroid belt with Jack Kennedall, who's passed. We all did things a certain way, and things ranged from very aggressive to nihilism. And basically, the only thing that anyone agreed upon with thyroid eye disease was that smoking was no good. And if you stopped smoking, people did better. That's the only thing that universally was accepted in the literature. You could find support for all the different therapies for and against. And Mayo came out and said, radiation therapy doesn't work. But if you looked at how they did their papers, they clumped instead of split. And there's different cases that different treatments worked for, but there was so much bad literature out there that it was just very widely handled ways of doing this. And in Europe, they came out with what are called the UGOGO trials that supported high-dose steroids for 4 to 8 weeks intravenous, and they're still doing that predominantly because they don't have access to these other medicines. And now that these other medicines are coming in, the IGF-1 blockers and others, the whole scene is really changing. And the disease is unusual because you'd say, oh, if there's a problem with the thyroid, control the thyroid and it should control the eye disease. It doesn't. Once it starts, the eye kind of disease kind of progresses on its own. Whether people do worse if the thyroid isn't controlled, but controlling the thyroid doesn't control the eye disease. And there were cycles of inflammation and relaxing, inflammation relaxing, that would typically last over 2 years in the people who it affected their eyes. And so people would complain of, swelling in the morning, redness. A lot of that stuff was just irritating and cosmetic. But some of those with the recurrent inflammation would then go down. So, some people then had just inflammation here, but others would develop inflammation that led to all of these changes that were debilitating and deforming. And so often you would try and control the disease, and then you would have deformities, double vision, eyeball sticking out, all that kind of stuff. And then all that was left was surgical. And our surgeries were good, but they didn't fix the intrinsic problem. They put a Band-Aid on it, basically. So if the eyeball was sticking out of the head and the eye muscles are fakaked and enlarged, you'd want to try and adjust that, but you couldn't. So what I would do is go in and take the bone away from around the eye, maybe take out some of the fat, make more space. That drops the eye back into the space around the eye that you've created, the bone. But that's dropping into the sinuses, and as things drop into the sinuses, then the eyes get more fakaked. And I'll show a picture of that. And so these medicines, though, attack the inflammation and can actually reverse some of these changes. So it's an interesting game changer. It's a good time now to have thyroid disease if you're going to have it compared to 5 or 10 years ago. All right, so this is one of my first experiences with Tepezza, teprotumumab, and this is published. It's okay to show his face. And I was supported by this company. For this is my first support by them. This was when they were Horizon, and now they're Amgen. And he had a really horrible looking orbit. Notice his eyes are a bit straight here, though. All swollen, his face is swollen. Some of this is steroids that he was on and off, on and off. And look at how, these are muscles on a CAT scan. That's the optic nerve. If you want to say that this muscle, it is a little bit enlarged, but it's close to the size of the optic nerve there. And as we go farther back, you can barely even see that optic nerve. These muscles are huge in a cone of a cone of bone, and they're being compressed. He's losing vision, and interestingly, so he's very swollen. Interestingly, because the muscles are reasonably symmetrically enlarged, his eyes remains relatively straight with this. And I would take him off medicines, you get worse. And he's heading for surgery, but if you operate when they're hot and active, you'll fix things and it just worsens. And you can even set off worse inflammation when they're hot. So along came Tepezza, and it had been, there were a couple of articles in the New England Journal of Medicine that was showing its success over the years prior to this. And they applied for FDA status. And right around COVID, it was just coming out to be FDA approved. And the company actually, we couldn't get it. And then the manufacturer of it went by the wayside when we went to the vaccines. And so they provided on a compassionate basis through a grant, a trial. And this is one of the patients who got it, one of the first patients outside of its initial trials over the prior half decade after the publication of the paper. And you can see this was unheard of to have this kind of reversal. But here he is hot. Just ignore these. These are me straightening his eyes out for now. He's hot there. And now his eyes are quiet. And look at how the muscles have regressed. Like look at, for instance, look at this muscle, go to this. And he's published because we treated his optic neuropathy, one of the first papers, but everything regressed. Interestingly, he had this unusual reaction where the improvement in the eye muscles was asymmetric, and so his eyes deviated. And they were deviating. This is after his treatment, before surgery. They deviated in between, but after the treatment, it actually accelerated the deviation. So there's still some things to be worked out. And this led to, some more eye muscle surgery, and the eyes are red because this is on the operative table, and I was able to straighten it out. So he went from looking like that. His eyes are white and quiet now. It's straight, and he's happy. He's super, super happy. And his eye muscles have regressed with their swelling and reversed. Great stuff. And he was, and here is, this is before surgery, and then we straightened him out, and it shows the regression of his muscles. And this is incredible that teprotumumab can do that, as well as this class of medications. And we published like a multi-center trial on the treatment of optic neuropathy with this. The problem with this medicine is if you want to get it, it's depending on where you are in the country, it's 8 infusions. It's an antibody. It's associated, as the other in this class, with hearing loss, exacerbation of diabetes, exacerbation of hypertension. You can't take it if you have inflammatory bowel disease. Lots of aches and pains when you're getting it. But the real problem is it's $350,000 to $500,000 for the 8 infusions. And it doesn't work for everybody. And the disease can recur, and so then you're treating multiple times. But it does incredibly. And this was another patient that I saw who had an other component of thyroid disease with the swelling. And there's a variety of different forms of acropathy and apocryphy, two different things, but lots of swelling. One is associated with bony changes. And her legs were so bad and her eyes were so bad, she couldn't even wear shoes. And this is what her hands are. And this is after she got the teprotumumab. Just amazing. And it doesn't do this for everyone. And this is a rare presentation. But when we saw this, it became a publication. And David Kelly is actually one of our residents now who just got a fellowship. He's going out to California, and he helped me write this. So once you develop a medication, competitors come along. And so I was supported by Horizon, then Amgen. They helped pay for that. I published that paper, and then when there wasn't a whole lot, it would cost me money to publish that paper. And so after it was published, I went and I sent the information and look, your paper's published. It's your, to Horizon, and they then sent me a check to pay for the publishing fee. So that is how it works. Viridian has made a similar molecule. It had initially been VRDN-001. Now they have 002, 003. And it is been very successful. We'll talk about it. Veligrotug is the molecule, and it's being submitted for FDA approval. And we've been very active. We're one of the main centers that are doing this phase 2 and phase 3 trials. This is just, when Dr. Zarbin was showing what the faculty do and the productivity, this is just an incomplete list of the recent publications and presentations. And I'm an author on all of these, or some of these, or most of these. It's more, but I just put up one page. So this contributes to our academic productivity. And so I thought that I'd go through a little bit more about the specifics of this medication. So once teprotumumab was out there are other companies that are creating competitors from a variety of different ways. They're making similar molecules. They're changing molecules the way they can be administered, and talk more about that. There's now a company that is trying to create an injection that will cause cells to essentially produce these medications if you give an injection behind the eye. We're working on with all those companies, trying to develop that type of thing. So Veli, if you don't mind me just calling it Veli, it's a long name. Veli is a similar molecule. It's an IGF-1 blocker. We don't know all of its characteristics, and the data that I'm going to present here is given to me by the company. I've got access to their data as an investigator, but I should be considered an entity of the company for this part of the talk, because I'm supported by them as I'm a consultant advisor and a researcher for them. To give you a scale of things, there's about $1 million to $1.5 million in studies that have come into this, institution through this company, that type of thing. I like this medication because I've seen its effect, but I want other medications that are effective, safe, and have the ability to drive down the cost so my patients can get them. And that's one of my chief interests, helping my patients and making things available to them. So they have a molecule that's very similar to Tepro. It attacks the IGF-1 receptor, but it binds a little bit differently. It does just about the same thing, but if you change the IGF-1 receptor, if you molecularly alter it, this medicine continues to bind to it, and Tepro doesn't. So it's a different medication, but it works extremely similarly. So we don't know all the side effects of this medication, but I would assume in the safety data that I'll present, they're extremely similar to Tepro, the list that I gave, although maybe different distributions. This particular medication is given, we'll go over it, but it's given right now as an intravenous 5 infusions, half a dose. And so hopefully, we'd like to be able to say that for the patients at a lower dose, we have different distribution of side effects or severity. We don't know that. And it could be worse because it binds in a tighter fashion than Tepro, so that if you actually look at some downstream modulators on a chemical basis, you look at phosphorylation, a chemical reaction, this is a complete blocker versus the other medication that's incomplete. And so all those things are to be worked out, but there's no head-to-head trial right now. So you're not legally allowed to compare one to the other. I can give opinions, but I can't legally compare them. So I'll speak to this, and all this information is available in clinicaltrials.gov and the company's website. And notice Rutgers, New Jersey Medical School is listed first. We like that. So I think I've gone through essentially these disclosures already. I have to say it's investigational only. It's safety and efficacy and not been established by a regulatory authority. And I already discussed any conflicts of interest. So as we talked about, TED, thyroid eye disease, affects quality of life, visual function, double vision, mental health. And we believe that more options are needed. And so currently, again, only one FDA-approved treatment exists. There's some other medications out there that have been repurposed. For instance, Actemra, thank you, which is an IL-6 blocker. Thank you. That you may know about from if you have giant cell arteritis, temporal arteritis, or rheumatoid arthritis. And it seems to help, and a lot of doctors are looking at that. May not have the same side effect profile, but it works with different different modalities along that inflammatory tree. But Tepro is the only FDA-approved drug that's out there on the market now. This new one, the Veli, is a full antagonist. It's a human monoclonal antibody similar to Tepro against the IGF-1 receptor. And its ongoing treatment is at the level of phase 3 trial. And we're going to be talking to the use of this in active disease, defined as patients. There's a clinical activity score, how red your eyes, how much pain you are. So patients had a certain activity level that had less than 12 months or less of symptoms, as were called active, and others that could have any clinical activity level at different times, depending on what study, and were greater than 15 months in duration, as were called chronic. And we'll talk to the results of those. So the study I'm going to talk about are patients who are the chronics. They have moderate to or severe thyroid disease with greater than 3 millimeters of the eyeball sticking out. And in this particular study, any activity level, they could have pain, not have pain, red eyes, not have red eyes. I mean, they had to have symptoms of greater than 15 months of duration. And this is published on clinicaltrials.gov. So this particular trial is a global trial. There are participants from Australia, France, to some extent with Turkey, in Asia, the United Kingdom, United States, New Zealand, Australia, and global trial. Okay. Not sure we're missing a slide. I don't remember what that was. So let's talk to the trial design. So patients got placebo or the medication. And after first sets of safety trials, etc., patients were randomized to 5 infusions instead of 8 every 3 weeks. And for every 2 patients that got Veli, 1 would get placebo. So these had to be people who weren't in trouble with their eyes. It's hard to find sometimes, but it's relatively severe disease, moderate to severe, who could withstand getting a placebo. And then we're going to look at how their eyeballs sticking out, which is quantified in 2 different ways, by a measurement called Hertel and by scans, by the clinical activity score. That is a 7-point score. If you have pain, that's a point. If you have pain with eye movement, that's another point. If the eyeballs are conjunctiva, surface is red, that's a point, and so on and so forth, up to 7. And looking at quality of life and fat and muscle volumes. And then this was primarily assessed. And then if they didn't respond, both groups would then cross over to get open label drug. And that study is ongoing. And so this gets technical, but the patients are about 50 years of age. On average, most are women. They have typically about 3 millimeters of eyeball sticking out, proptosis. On average, they had clinical activity. They had double vision, and this was scored by something called a Gorman score. If you had no double vision, it's a 0. If you had constant double vision, it's a 3, and then divisions in between. And basically, the bottom line is with this medication and the use of it, we're not getting into all this technical stuff, but it met all of its primary goals. That the double vision went away in a lot of patients. It improved in a lot of patients. The eyeballs sticking out got a lot better. Their clinical activity scores dropped. It really did a good job. So this is comparing the actual data with the responder rate. This is by Hertel and how much it went down. The interesting thing is there's a large response rate by 3 weeks by the first infusion. And that continued to go out. We don't know how durable this is. We'll have some of that data at 52 weeks. So great stuff, right? Similar to the Tepro. And one would have to discuss the side effects, which I'm not going to get into all the percentages. It doesn't really matter. But I would just consider it extremely similar. The companies will argue back and forth, who does what, but all that stuff gets worked out when you have multiple numbers. But I'd also add to menstrual disorders, which I didn't. So these may not be the best medication for a young woman who is planning to have a family soon. The majority of the adverse events in both arms were mild. Notice that the placebo patients have similar side effects as the people getting salt water would have some of the same side effects that the patients who are getting the real drug do. So the conclusions are that 5 infusions of 10 milligrams per kilogram of Veli, and Tepro is at 20 milligrams per kilogram, led to significant improvement in proptosis, double vision, and symptoms, and we're seeing it very early, as soon as 3 weeks. That's at the first visit. I actually was watching some patients closer for a variety of reasons, and we saw their visual loss regress prior to 3 weeks. Really amazing drugs. And the company is particularly proud that this Thrive-2 data, that's the name of the trial, Thrive-2, is the first to show in chronic thyroid eye disease that there was significant improvement in double vision, which the other studies that were not designed to show, basically. And this did it. There were similar results in patients in that active group who had the higher CAS. This allowed any disease activity score in that was a grade 3 or greater. I don't remember actually if it was 4 or 3. And one of the studies changed during it. But it was also well tolerated in the acute group, and they had similar effect profile. So Veli seems to be a promising new treatment option in active in chronic thyroid disease. And we're now enrolling, we're looking at the ongoing treatment out to 52 weeks, as I mentioned. They're submitting for FDA approval probably in the second half of 2026. You can keep an eye out on the stocks. And we're moving into a new form of the medication where they took this medicine and engineered it. So just like the semaglutides, Ozempic, all those that are subcutaneous injection or intramuscular injection. And this can be used at an extremely low dose. And so we're moving into subcutaneous trials that are available here. And we have 3 of those trials ongoing here. I just enrolled a patient. Thursday when I got sick, I enrolled my first patient in one of the trials and then went home. My voice. So thank you. This is exciting stuff. We are now in neuro-ophthalmology, orbit and oculoplastic surgery where Retina was 15 or 20 years ago. And I'd like to just call out the OCT that in the OCTA was donated by the Friedman family. There were a couple of my patients who were using it in all the stuff. So thank everybody. Thank the Lions. You guys have been incredibly supportive, and we couldn't do what we're doing without you. And I look forward to next year's wine pairing. Yeah.
Question.
Sure. I'll start here.
Go ahead,
Back and then, yep.
Okay, I was diagnosed with Graves' disease in 2017. I had the radiation treatment on March 1st, 2017. I see Dr. Froman here. I had double vision, especially at night while I was driving. He had prescribed flip sunglasses, prisms, which at this point in time I very rarely, if ever, used. I take levothyroxine once in the morning, prior to about a half hour to an hour before breakfast. And when I last saw Dr. Larry, he said he was very satisfied with the way things are going.
That's fantastic. So I think what you're speaking to is that there's a really wide variety of how severe the disease can be. And in general, many patients will progress over a couple years, and not everyone goes through that whole phenotype. You can have a little, you can have a lot. And that's why these are reserved, especially for with the side effect profile of the cost for patients who have at least a specific severity. I'm very happy that your problems have regressed and that you're doing well with kind of standard low grade therapy.
Works.
Yep.
The gentleman that you were showing with the TID, what was the time frame there? Approximately.
So he probably had, I'm trying to remember how long he had signs and symptoms for. I'd have to go back to the paper, but if he'd had signs and symptoms for a year and a half prior to seeing me, then we treated him with standard therapies over 4 to 6 months. And we're going to move towards rituximab, which I've used as in my really bad cases, and when this medication became available. So between when his eyeballs were sticking out of his head and the pictures when he was quiet but double, or strabismus dysmotility, if you're talking about 3 to 4 months, something like that. It's a life changer. It's amazing. We typically see a lot with the Tepro stuff. We would see a lot of the full action by about the 5th dose, 4th, 5th dose. But you can, even with the Tepro, I've had personal experience. I'm not comparing the two, but personal experience where, extremely quickly after second infusion. I think most investigators will talk about by second or third infusion. With this one, I saw it about the first infusion. Is interesting. Yep. Okay.
On the very last slide for the Aveli, you had the subcutaneous injections versus the infusions. Would that lower the cost of the drug?
So I think theoretically, yes. There's a lot of marketing in there. There's a lot of FDA. I've actually not been, I'm still young, even though I'm gray. So I haven't taken, my dad was silver by the time he was in his 20s, and I was a redhead. I got a ginger, my young one's a ginger. I haven't taken a drug from phase 1. This is my first experience going from phase 1 through phase 3 and FDA approval. So one would just hope that it will push down the market. I think it will. But these other injectables are very expensive if you're, the semaglutides. But that's what the investigators who invest their time and thought process in this hope to. And we don't actually know if this will be effective. We hope it will be. It's designed to mimic the amount of molecule that's in the body of the people who are getting infusions, but it may even be that we don't. When a medication comes out, it's considered a panacea, and then you realize that there's other problems with it, and it's not as effective as you thought, and there's side effects that, if they're happening at 1 in 1,000 or 1 in 10,000 or 1 in a million, you start seeing them, and a variety of different things happen in the evolution of an agent, and so we're seeing that, and you'll see a lot of that with teprotumumab because it's been out there. Now there are a lot of people getting it. One of the things that we're finding is a recurrence rate that was not as expected as the initial data thought. So it may be that, okay, you treat patients with intravenous first or one of these agents, and then you need something to manage them. There are not very many medicines. Like if those of you who have a rheumatologic disease, you probably still take the medicine. You don't just treat once and say adios. And so that idea is coming out with this. But if you've got something that, if it's 8 infusions at $500,000, what is that? Let's say $75,000 an infusion or something like that, or 50 to 75,000. That's an expensive way to go. So maybe you treat with one and then sub-Q with the other. I'm not allowed to say that, but that's what because we don't even have an effective medicine. It's not FDA approved, but that's would be a way to think about it. Or even these medicines and the IL-6 inhibitors. We're at an infant stage with this. We're learning about this, and we're doing the best we can as we go along. It's actually very, very exciting as a clinician.
Thank you.
Yep.
She asked my question. Thank you.
Yeah. Anyone? I highly recommend the cloves and the chocolate and the cinnamon on the island of Grenada and the fishing. If anyone needs to, we have, so Clinton Bailey is the undertaker, one of the undertakers on the island. And it's great. Last year I showed, a person came up, she was on her honeymoon, if I recall. She came up to the surface, pulled off her mask in the water, and got hit by something in her face. And it turned out that there was a ballyhoo that hit her, and she didn't know the ballyhoo got stuck in her orbit and came to the US. And I showed these CAT scans last year in MRI with the ballyhoo, and we published it and we took it out. And she did great. And I have my fisherman, so I've now published with my fisherman. Clinton Bailey is an undertaker out there. There's 2 on the island. I say half the people on the island meet him at least once, right? So he's a great fisherman. When I was just out there, I didn't get the fish because he fishes a tournament, and all the great fishermen on the island were at the tournament, so I didn't go out there. So that means I have to go out there twice a year now to get my fishing in. If anyone needs some fishermen on Grenada, let me know. So I've published with him. So his boat, his name is Clinton Bailey. What would his boat be called? Irish Cream. Yeah. So, yeah. So thank you all. I think we got to all the questions, and I'll turn it over for the final comments. Yep.
Thank you so much, Doctor.
Yeah.
Having been to 20 plus of these over the years of my association with LERF, I have yet to see a repeat performance on a particular topic. So it just means that there's so many more things for them to tell us about in the future. We're really glad everybody got to be here today. Got to see the show, and hopefully everything else worked out fine for our technical staff. They had a lot of challenges we got here because of a power failure last night that knocked everything off.
Wow.
So they managed to get us up and running before we were on time and start the show. One thing for Dr. Iyer, if you're using the portable OCTs that you have in the department, they came from us, both of them.
Yes.
And the other one that was a tonal pen that didn't have the right angle, we fixed that for your department as well.
Thank you so much.
And I can remember a number of years ago, and I'm going to say probably 10 to 15, we did purchase an OCT machine for your department as well. So we've been involved with an awful lot of things. Then Kathy Picorni gets an idea from one of you doctors and says, I need this or I need that. She presents it to us. Usually we have to take her out to lunch or something, and she tells us a story and tells us what she needs. We go back to the trustees, and so that's the kind of thing we do. We've been here for your students as far as your residents. We do with the research plaque at the end of the season for their graduation. So is it next Friday or the Friday after?
It's next month, yes.
Next.
June 24th.
That's the graduation. I'm talking about the research papers presentation.
Oh, yes.
That's on the Friday, but I forget if it's the 13th or something like that. But the question I got asked earlier tonight, is that going to be in this building or is that going to be over in the lean room in the other building? And I said, we'll have to ask the people who know, because I don't.
I believe it's the other, it's not here.
It'll be in medical science building, okay. So with that, you got your calendars you can fill out for going to see what they present. If this was too technical for you, come anyway, because after you do it for 20 years, you pick up at least 2 or 3 words while they're talking. So it's really been great. But thank you all for coming and being here, and make sure you help yourself to whatever you need in the back as you're leaving, and make it less for me to have to take someplace. So thank you all again, and we'll talk to you next year.